Right, so tēnā koutou katoa. Welcome to the Wednesday night webinar party. Tonight, Toni Johnston is going to lead our knowledge journey. Toni comes with a wealth of knowledge, 25 years plus to be exact, on both hospital and pre-hospital experience. She is the Associate Charge Nurse for the Airway Medical Evacuation Flight Service offered by Dunedin Hospital ICU. In addition to this, she is the chair for the College of Air and Surface Transport Nurses. Tonight, Toni's webinar is titled Trauma Assessment and Care of the Trauma Patient.
Thank you very much for joining us tonight and listening in. And I'll do my best to get us through this hour. Please, if you have any questions, feel free to forward them on the chat to Catherine and we can address them if we need to. So I've got a few slides, we'll crack on through it. Basically, what I'd sort of like to do today is to talk a little bit about trauma assessment and treatment, and then looking at the ongoing care and referral, which of course will be really different depending on where in New Zealand that you're logging in from. So we can talk a little bit about the major trauma network and the spinal cord injury pathway as well, which I've got a little bit about at the very end. I guess for most of us, we have different ideas of what trauma is, and having had a decent local praying, as we call them, yesterday, involving 6 occupants, which when you've got an ambulance service with 3 ambulances on the road most of the time, that actually takes up pretty much all the vehicles and all the resources available to you. Although we don't have a huge amount of trauma down this end of the country, not like somewhere that deals with like the Napier, Taupo Highway, we do get a little bit of our own stuff. So there's a wee bit of difference too between the urban trauma that we might have, where you're literally 5 or 10 minutes down the road from your local major hospital, or something like you see in the current slide where it's more rural and remote, which can put a big strain on certainly a lot of different services, and certainly for you guys as health professionals that may be assisting in that role. No matter where you're starting from, it's useful to have some sort of, framework to start off with looking at your patients. And we call that in St John a critical action checklist. So it's what needs to be done immediately, sort of looking at saving lives, preventing that secondary or ongoing injury, further trauma. And for us in ICU, that's looking at things like hypoxic brain damage and things like that that might have come about just because that initial first action wasn't taken, or it could have been done a little bit better. So if you think back to your days of doing ACLS, where we had the doctor's ABC mnemonic, you can actually apply that to pretty much any situation, any clinical situation. So even in the hospital setting, it doesn't have to be pre-hospital or rural. So really important to think of your danger and your own safety. And this is not just in the pre-hospital setting, but if you think about some of the trauma patients that come to you, it may be that they've got shards of broken glass, bit of metal poking out of them. You know, it's the spear fishing thing that's gone through their foot and the spear's poking out the other side. And sometimes it may just come down to the actual behaviour of the patient that might be a risk to your safety and certainly dangerous to you. So that's the D part of it. A stands for airway, and in trauma we put airway plus C spine. So that's a consideration where maybe that managing an airway, you can't just sort of do the triple airway manoeuvre, you have to think of that C spine at the same time. B, of course, is for breathing. For a start, are they breathing? And then are they breathing adequately enough? C for circulation, and that also comes with sort of severe hemorrhage management as well, or certainly recognition of severe hemorrhage with that. D stands for disability, so that covers your neurological, your brain and your spinal cord injuries that may be part of that. E is for exposure, and that's exposure of your patient either to the current environment or fact that you actually have to expose them to see what's going on, because if you don't expose it, you can't find it, so you can't treat it. And then the F part, which I think is really important, especially if you're rural and remote, is for forward planning. It's what do I do next? You know, once I've actually plugged the hole, stuck my finger in the leaks and all the rest of it, what am I going to do with this patient next? And so that's often done right early on, because it may be that you're working like we are down in this part of the island, where we cover 28% of the land mass, and we have about 6 to 8% of the population scattered throughout that. So some of our really, really remote places need to think really early on about what resources they're going to have, because if we're looking at flying, and we fly a lot via helicopter, majority of our legs are around about an hour in flight time. So, you know, that's a long time for somebody to be at the other end waiting for help. And that's probably really different from, say, the North Island, where your flight journeys are quite a lot shorter. If we talk to my compatriots that work at the Auckland Rescue Helicopter Trust, a lot of their flight times vary from, say, 10 minutes to Waiheke Island to maybe 20, 25 minutes to the Coromandel and things like that. So quite different. So that forward planning comes into play really early on. It's really, really important. Like anything, you have an initial approach to your patient, and so that's sort of what do you see from the endobediagram, or, you know, when you walk in the door, or when the patient arrives to you, depending on where you are, or you arrive at the patient if you're in a prime nursing kind of situation or a primary response. So if we look at their initial approach and their level of consciousness, we quite often will use the AVPU system rather than a formal GCS, because unless you use your GCS every day, you can never remember what the 3 components are, and then also how to score each of the 3 components. And I think one of the downsides of the GCS is that it actually, you know, you can be completely hemiplegic on one side, but if you're following everything else on the other side, you score a GCS of 15, which to me seems a little bit wrong. So going through AVPU, which A stands for awake, V stands for response to voice, P stands for response to pain, and the last one, U, is either unconscious or completely unresponsive. And so I think that's really, really an easy, quick and dirty way of doing it. You can write down AVPU and you can just circle the one that applies. So it's an easy documentation as well as trying to work out exactly what you're going to do for a more complicated GCS. Your GCS can come later. So that's the first part of it if you're having a quick look at your patient. Next up, of course, comes airway with your C-spine management. And so it's really important to remember that any noisy breathing is a sign of some form of airway obstruction. And any form of airway obstruction is going to give you, or has the potential to give you, some form of probably hypoxia and hypoxic brain damage as a result of that. So it's really important to be mindful of that, but it's also important to be mindful of the fact you have to consider that C-spine injury that goes along with that airway. So having a look at the way that they're presenting, you know, were they lying in a particular way? If they're a motorcyclist that's been picked up off the road, how were they presenting when they first been picked up? To put them back into a neutral alignment is not going to cause any further injury to the C-spine. But if you then put them into alignment and then you start looking at how you're going to tilt their head, if you're thinking of how you're going to manage an airway, then that's where you're likely to cause further damage to that C-spine. So for a start, have a look. Are there any visible obstructions in that airway? You know, the loose teeth, is there any blood? A bit of chewing gum maybe floating around, some secretions, anything like that. And can you get rid of that reasonably easily without doing too much and without having to move them too much? The general rule is if it's GCS less than 8, then you're going to have to intubate. And so that is really, really important too. Do they have a cough or a gag? Because of course, if you have cough and gag, and then if you put a laryngoscope in their mouth, it's going to give you a rise in their ICP, or have the potential to create a rise in ICP. So if they do have that present, then you're going to have to think about how you're going to manage that and look at your induction agents prior to doing any of that. Specifically, if you think there's also an associated traumatic brain injury or potential for that. So that would sort of maybe garner how you're going to approach that. But remember, you know, noisy airway is an obstructed airway, and so that needs dealt with reasonably quickly without going on too far. B stands for breathing, and for a start, you know, is the patient breathing? You know, is it adequate then when you look at it? So anything less than 10 or greater than 30 gives you rise for concern or cause for concern. If they are awake and they are able to speak, how many words per breath can they get out? You know, are they then gasping in between? What do they sound like? What's their pattern of breathing like? Do they have a paradoxical pattern of breathing where your chest goes out but your belly goes in, and then conversely they breathe out and their belly goes up and down? How hard are they working to breathe? Are they really struggling? Are you starting to see some of those external signs where you maybe get a bit of nasal flaring, get a bit of indrawing, maybe a bit of tracheal tug? They're working really, really hard. You're seeing that abdominal muscles working as well to go with the breathing, and they look like it's actually a lot of effort. When normally we would just be sort of, I guess, like this. You don't think about breathing. It's something that just happens completely normally. You need to have a good look at the chest. So you're doing IPPA. For anybody that's done any health assessment, it's inspect, palpate, percuss, and then auscultate. So expose the chest, have a good look, run your hands around it. What can you feel? Are there any holes? Do you feel anything wet? Maybe even if you've got gloves on, is there something a bit odd? Also being mindful to keep a wee eye on what might be sticking out of there. Is some metal, is there glass and things like that on them for keeping yourself safe? If you're in a helicopter, you can't listen to anything, so you do a lot with your hands, with looking for a start, and then putting your hands on the chest. Can they take a deep breath in if you ask them to? Does their chest move equally? Can you feel any deformities? Not that you go looking for crepitus, but usually if they've got some fractured ribs, the minute you put your hands on their chest, you can feel that. And you can feel any deficits. You can feel something like a flail segment where a little bit's popping out and the rest of the chest is going in, and those kind of things. So that's sort of paradoxical of, as you breathe in, a bit pops out and gets sucked around. So if you do have the opportunity to percuss, you're listening for resonance versus dullness. So everything should be resonant, which means there's air in there. Anything dull means that you're over something that's a bit solid, whether that's a bit of lung, that's a bit of blood there, or if you're down the bottom of the lungs, maybe it's a bit of fluid sitting in the bottom of the lungs, whether that comes from blood, whether that comes from a bit of heart failure or other things that are going on. And if you think that they're really hyper-resonant, it sounds really, really like a very tightly wound drum, then maybe there's a little bit of extra air sitting where it shouldn't do. Along with that, sometimes you can actually feel some of that subcutaneous emphysema as well, or you look at them and they sort of look a bit puffy, and the minute you touch their face or touch their neck, you go, oh, there's that Rice Krispie feel, and you think, oh, there's a bit of air escaping somewhere. Then if you do have the ability to auscultate, it's just a case of, listening for some breath sounds. And if they're really short of breath, go straight to the bases of the lungs first, because if you're only going to get them to be able to take 2 or 3 breaths without being short, without being too short a puff, then you want to sort of hear exactly how much expansion they've got. Air's always going to rise to the top, so they're usually going to have some air up the top. Although, once again, if they've got a pneumothorax, often that's where you'll find it first, because that air escaping from the lungs is going to rise to the top of the chest as well. So it might be a wee bit hyper-resonant on percussion, but a wee bit quieter from a breath sound point of view at the top. Pulse oximetry is always an interesting one, because A, if you're just on the side of the road, you don't have it. But B, also, pulse oximetry is not just about the amount of oxygen in the blood. Of course, it actually relies on having some circulating volume for a start, and it relies on them being sort of warm and pink and all the rest of it to actually for it to work. So even if their sats are down a wee bit, you sort of take that into account along with the rest of your respiratory assessment, because it may be just the fact that actually they haven't got enough hemoglobin, or they're cold, they're shut down, and it's actually not reading properly, versus actually whether they're breathing and getting enough gas exchange. So that's something you take into consideration, but it's not the be all and end all. Your physical assessment of that breathing is much, much more important than reading somebody's sats. Granted, it's really easy to stick a SATS probe on because you often get a heart rate in bits and pieces as well, but it's that sort of, you can't beat laying your eyes and your hands on that patient for a start. Things that you need to consider with that trauma are things like tension pneumothorax, open pneumothorax. Of course, you can often see, that open sucking chest wound. So you assume that there's going to be a pneumothorax there if you've got that. Significant flail segment. So you might have something that's a little bit smaller. Maybe some of the ribs are cracked and not completely separated, so you get a wee bit. But versus, you've got ribs 1 to 8 gone on one side in 2 sections, and so you actually see that bit popping out. And they can be really real challenge to deal with. Sometimes it's as simple as sticking your hand on it to try and use the hand to splint it, or in the past, sitting a big bag of IV fluids on it, putting a bit of sleep tape over it and just trying to actually do that. I've got a consultant who will grab sort of a couple of bags of peritoneal dialysis fluid or something like that that's about 2 kilos worth, and I remember him sticking that on the front of somebody's chest and taping that on one day just to try and see if he could improve lung mechanics. Not much you can do a massive hemothorax unless you have the ability to put a hole in their chest and do a finger thoracostomy. These days, pre-hospital, that's being taught much more often than actually putting a formal chest drain in, because putting a hole in the chest, putting your finger in, you can relieve a bit of that tension as far as any pneumothorax goes, but also if you put a hole there, you may get some blood coming out as well. We're teaching people these days to, use maybe a colostomy bag over that kind of thing. But if you think that you're having trouble because you've got a sucking chest wound, one of the easiest things to seal up a sucking chest wound with is actually a defib pad. They stick really, really well, seal really well around the outside. And if you need to, you can always pick off the edge, let a wee bit out, if you think they're tensioning, or let a bit of blood out and stick it back down again. So they can be a really helpful thing in your first aid kit, and they'll stick better than anything like a tegaderm or anything like that doesn't like being wet. So that can be really, really helpful. Need to consider if you're going to do any interventions, and that would be if your arrest rate's under 10 or if your arrest rate's over 30, maybe you're going to need to think about some help for that patient because they're working quite hard. C stands for circulation. So for a start, does the patient have anything? What do they look like as you walk up to them? Are they pale? Do they look shocked and all that, the cold, clammy, sort of white, grey looking? Or do they look red? So that's always a sign there's a bit of hemoglobin running around somewhere. Do they have a palpable pulse, and where can you find it? Palpable pulse in your wrist tends to disappear, maybe with a systolic blood pressure around 70 to 80. It may disappear at your neck when you're getting down to the 60s. The same for a femoral pulse. It's always a little bit weird if you go diving straight into a femoral pulse, hands down their pants and things like that. So I often usually work peripherally and see how you can go from there. What rate is it? Is it regular? Is it full and bounding? Is it weak and thready and things like that? And along with that, as you're laying your hands on them, what does their skin feel like? Are they flushed? Are they cold and clammy? They diaphoretic, and you take one look at them and you go, oh Lord, something's not going right here. Whether you think it's cardiac, whether you think, they're looking like they're shocked and maybe hypovolemic. When you touch them, what does their temperature feel like? Are they cold? And is it just because you've been lying on the road in the middle of central Otago, or last night when I was working in Mosgiel, it's -2 in the middle of the night. So, it's purely the fact that it's actually cold in the environment, let alone, are they cold? And yet, hold on, you're lying on the middle of the road in Kaitaia and it's a 30-degree summer day. So that may give you some indication of what's going on as well. Capillary refill time, quite often have a look at their peripheral capillary refill time, and also central. So, sort of a bit of pinching on the front of the chest, basically over the sternum. And what's that looking like? Is there quite a lag between the two? So it may mean that they're okay and sort of centrally all right, everything's been pushed to central circulation, but they're a bit shut down at their peripheries. So that can also, looking at the two of them, can give you a sort of an idea of maybe what their circulating volume's like. It's being all pushed to the middle, or it's sort of, they're still perfusing their peripheries as well. Control anything you can see. So stick your finger in the hole. Hopefully you've got gloves and things on. If you don't have gloves, you might have your hand inside a plastic bag, which you can also use if you don't have gloves available to you. So that direct pressure is really, really important. And it's the first thing. We always used to talk about pressure, elevate and pack. So that was, if it's an extremity, stick your fingers in the hole, elevate the limb above the level of the heart, and then pack it with something that's going to stop it bleeding. And of course, one of the things that's come out of primarily the wars in Iran and Iraq has been the reinstigation of the use of tourniquets, which you'll see. And all ambulances these days will carry them. They're called, the one that's common is the one you can see in the photo there. It's a CAT tourniquet, so combat application tourniquet. And they found that overseas, the soldiers that were dying from blood loss, and it was primarily from explosive devices, AEDs, and if they put them out in the field, and they would put a tourniquet on up here, and around their femorals as well. And basically, if they got a limb blown off, either they could pull it tight themselves, or the first person that got to them would pull that tourniquet tight, which is why we were seeing people sort of arriving home with, 1, 2, 3 or 4 limbs blown off, but at least they were surviving because their body armour protected their centre mass, but it didn't protect the extremities. So that's where a lot of the tourniquets have come back into use from, and actually showing that they're very useful when it comes to surviving. This photo was a motorcyclist I picked up out of Lakes District Hospital, and actually if you look to the very right of the picture, you can see something orange just at the bottom of his leg there, and that's actually a cat tourniquet. They couldn't see what was bleeding when they picked him up in the field, and they couldn't see whether it was arterial or venous, so they put a cat around his knee, which is at the right hand side of the photo, and that's his foot at the left hand side. I got to him an hour and 10 minutes after that had been put on, and it was interesting. It probably wasn't quite tight enough, so he actually got some arterial flow because I could still get a palpable arterial pulse in his foot. I didn't go for the posterior tibial. I couldn't quite work out where his ankle was. And so he was getting some flow down, but of course the blood wasn't going back up, so he was leaking a wee bit because he was getting a bit of venous engorgement. So I got a wee bit brave, and along with the doctor and I, it's like, rightio, I picked a bit of gravel and bits and pieces out of that wound, and let's take the tourniquet off, see what happened. And it actually wasn't leaking too much. So I flipped the skin back over and sort of wrapped everything back up, and we headed for the hills. It took us 50 minutes to get home. And that guy actually, despite having had the tourniquet on, because he still had a wee bit of arterial flow, actually kept his leg after they spent quite a bit of time reconstructing some of the bones and bits and pieces and some of the vessels, which was, sort of all credit to the ambulance crew. They really couldn't see what was leaking, and they sort of decided that putting that on for a start was really good. So it was applied really, really well. It was written on at the time that it was applied, and when I came to it, it was like, okay, been an hour and 10 minutes, let's see what happens when we take this off. By that stage, of course, he'd been in hospital, he'd been warmed up a wee bit, so as far as coagulation went, that should have kicked in. He'd had some TXA and some other bits and pieces. And so quite usefully, he was able to keep that leg. Some of the other things that you may use in assisting with managing the control of, certainly of hemorrhage, are splinting your long bone fractures. So that might be using a Sagar or hair traction splint, especially with femoral fractures. That can be really, really useful. Some of maybe your tib fibs, even pulling them straight, putting a cardboard splint on or tying them to the leg next to them can be really helpful as well. Something like the pelvic wraps, using either the SAM pelvic sling or just your old-fashioned, sheet that you've turned around, twisted around and tied to try and bring together those open book pelvic fractures can be really helpful as well. Also replacing your circulation, so a couple of large bore, preferably 16 gauge antecubital lines, with a judicious use of IV fluid. Don't just go pouring in lots of IV fluid, because all you do is dilate things, and of course, then you end up making things bleed. If you push the blood pressure up when you've got no control of your bleeding, of course, it just blows any clots off and makes them bleed more. So I guess it's that recognition of a little bit, but not too much. Recognising that hemorrhage is not controlled, and so once again that may dictate how much you're pouring in. If you've got controlled hemorrhage, you might be able to put their blood pressure up a little bit higher because they're not going to continue to leak. If you haven't controlled that hemorrhage, then pushing the blood pressure up probably isn't in their best interests, and that may also dictate what you're going to do next and where you're going to send that person. So it's that ongoing sort of, once you've done an intervention, having a good look at their heart rate, their blood pressure, looking at their skin colour, capillary refill time. If you put things like a tourniquet on or used a pelvic wrap, it's looking at that perfusion post or lower to that extremity and working out, okay, am I going to sacrifice a bit of perfusion to this dodgy looking leg or foot, in keeping with actually managing the rest of the patient and trying to keep them alive from stopping the leak. So that can be really important as well. Disability often can be a bit challenging, so it's that quick look to see, are they conscious for a start? Can they follow those simple commands? Can they move and feel things? And if they can, what can they feel? Can they, is it sort of, what level can they feel things? Are there any other indicators present that might give you a significant injury or look to be significant injury, and yet the patient might not be aware of it? Have they presented where they're lying flat on their back with their arms above their head like this, which is often indicative of some cervical spine injury, and it's like a normal reaction. Their hands come up and then that's it. They might be able to feel a few things, but actually they won't be able to move their hands necessarily down. And you may find very well that there's a sort of a low cervical spine or a high thoracic spinal injury with that. So those kind of indicators, have they come, is it high speed, what other damage is done as well, that it may indicate there's significant injury there with them. And that may dictate also where you're looking at sending that patient if you're looking at a referral pathway. So exposure and environment, you've got to strip them off, you've got to find it to be able to treat it. But depending on your weather as to how long you leave them exposed and how much you expose at any one time, you know, for us down south in winter, or if you're on a ski field or something like that on the side of the road, then pulling all their clothes off just to make sure you can see them head to toe maybe not serve their best interest. It might be you expose a little bit at the time, start at your head, work your way down, and as you've had a look, you then cover them back up again. You know, if you are rolling them to expose the back, then before you roll them back and lie them where you had them, consider you might be able to put something underneath them. You might have some blanket, might have a cardboard box or a newspaper or something like that, which is absolutely fantastic insulation, either be it from a cold road or a really hot road in the middle of summer. And while you've got them on their side, you know, doing that log roll and having a quick look at their back, slide something underneath them that might help with that as well. If they're really hot, then you may consider cooling them. And it may be, you know, if you're giving IV fluids, use colder IV fluids rather than heating your fluids to warm them up. If it's really cold, think about how you're going to prevent that heat loss, how you're going to gently rewarm them without, you know, rewarming them really rapidly and causing vasodilation and then dropping their blood pressure and causing you more problems. So sometimes it's as simple as putting, you know, a towel around their head. Looks really, really stupid, but it works really well. You know, exposing a little bit at a time and thinking about how you're wrapping them up. Even stopping blood loss, you know, with a bandage can actually save quite a lot of body temperature as well doing that. So having a bit of those kind of things going on and rewarm them as appropriate. And the F part of your planning stands for forward planning. Where does this patient need to go? Where is their path of definitive care? You know, you can do all the bits and pieces yourself, but actually what do they need in the long run? And so that may be looking at your major trauma network and looking at trauma pathways that are available in your particular area. And also within that, what transport services are available? We're finding more often than not that, you know, helicopters are being used much more often because there is a lack of road ambulance transport services. And that comes down purely to a personnel, you know, no longer can people be volunteers for as long as they used to be. You know, the things like the driving regulations now dictate I can't work a 12-hour shift at the hospital and then go and work for 4 hours on the road because we're dictated by driving regulations. So that may certainly affect how and where you send your patients after that. So that can be really, really important. So sometimes that early, you know, overview of working out this patient's way too sick for us to deal with. They've got this, this, and this wrong. This is where we'd normally refer them. These are the people I need to make a phone call to make that happen. And that can be done sort of really early on in the piece before you get into the nitty-gritty. We have a quick look, just going for a wee bit more definitive assessment, looking at GCS. So if you're going to start from your head to toe and work down from the top, that will give you a much more specified neurological assessment. And often if you're going to refer to a neurosurgeon, they'll ask what the GCS is. It can be really useful from a point of view of working out what their prognostics are, what that first one is, and having a good look. So eye openings 1 to 4, verbal response is 1 to 5, and M is 1 to 6. And quite often we'll write it, you know, E1, V1, M1. Your patient can be dead and still have a GCS of 3, which can be very amusing. I did see a GCS written in somebody's notes not so long ago of 2, and I thought, oh, I'm not sure how the medical consultant came up with that one, but we'll just leave that anyway. If for some reason you might have the patient already intubated when it comes to you at your facility, then often V is just written with a T beside it. So it's V means tubed. So that sort of gives you also, if you're looking at that from a clinician that you're referring to, means, okay, their GCS was so bad, somebody's already stuck a piece of plastic down their throat because they weren't maintaining their airway. So that goes, oh, they're not flashed from a start, and then we'll go from there. And then sometimes things like your motor response actually may be a really good indicator of what they're doing. Of course, it's the best motor response, so it may be they're completely moving one side and they're not moving the other side at all. But often, you know, that sort of flexion versus extension versus localizing to you doing something often will give you a really good indication of sort of maybe their long-term outcome. So that can be really, really important. Also, along with that, you know, are there any external signs of injury? Whereabouts are they? Can you look at their pupils, or do they have damage to one or both eyes? So that may dictate sort of a little bit about, you know, how you're going to dictate or how you're going to talk about that GCS and about pupillary response from that point of view. Are they awake complaining of headache? They may not have anything visible, but they're complaining of a headache. And when you look a bit further, you might see, you know, something like a bit of battle sign, which is your bruising behind your ears. You may find after a wee while with you, you start to see, you know, a wee bit of bruising turn up around their face. And so it's really important to have a really good look. Long hair, shift things like that. If it's tied up in a ponytail, undo it. Specifically, if you've got a ponytail or something like that, or a hairband that's holding hair back and you've got them lying on their back and they're lying in a C-collar or anything like that, take the hair out, because there's nothing worse that they're crying of pain, and it's actually just because the hair clips are digging into the back of the head and you haven't realised, or the C-collar comes right up underneath there and it's digging into the back of their head as well. So have a really good feel about that. If there's a C-collar on, then get them to lie still, take that off, because you actually need to have a good look up around the neck, in around the ears and everything like that. Take out things like dangly earrings if they do have a C-collar on, because having them tucked under a C-collar, is your patient will be crying and you're going, I don't know why, there was no indication of any injury, but it's actually something as simple as you've caught their earrings and they're either digging into them or they're tearing on the earlobe. So that's all done though, thinking about other distracting injuries. They've got an open fractured femur, so that may make sure that they're not aware of the fact that they've got a hole in the front of their head unless they see a bit of blood dripping down their face. So it's always done with that in mind, those distracting injuries in mind. Spinal injuries, yes, you can't fix what's already happened, but you can prevent them being worse by the way that you manage those patients. So poor management's been shown to have a really significant outcome on whether they've got ongoing or worsening injury, or whether you're maximising what they've actually protected so far. Often mechanism of injury, MOI, will give you an indication of whether there's potential spinal injury. So if it's something like a motorbike accident or a cyclist and they've been thrown, they're going to have a different impact than if you've been in a car where maybe you've gone forward and back with a bit of whiplash, but actually going through the air and landing on your head is much more likely to cause significant spinal injury. So that may dictate, or a decent fall, fall from standing height will give you a different suspicion of neck injury than a fall, off a 3 metre or a 10 metre ladder or a building. So clinically, you're able to clear that C-spine if they've got a normal level of consciousness and there's no tenderness on their C-spine posteriorly midline, and there's no signs and symptoms of any injury, and there's no other distracting injuries. So often you have to tick those 4 boxes to be able to clear somebody's C-spine. And you may find that they won't clear it radiologically until the patient is awake and able to tell you that their spine, they have no neck pain. That's fine as long as there's no coexisting traumatic brain injury. That means they're not going to wake up for a month of Sundays. So it's about sort of managing that along with it. C-collars aren't always appropriate, specifically, the stiff necks that you might see, because sometimes they actually cause more problems than what they prevent. If you've got somebody who might have a laceration or a bit of even a skull fracture at the base of the skull right at the back, the hard part of the collar actually digs right in there. And I had a gentleman who was involved in a gas cylinder explosion thrown across the room and actually split his skull from the front to the back. And the C-collar was sitting right on the back of the fracture. So, and he was really, really sort of agitated. The minute we took the collar off and actually put sort of a softer collar on and a couple of sandbags, he settled down really, really easily. And it was just, nobody was aware that it was actually digging in the back of the fractured skull. So it may be appropriate not to have a collar on. You'll find that ambulance services now will put a lanyard around their neck and it's bright yellow and it's got C-spine has not been cleared, and that should stay with the patient until somebody's had a good look at their C-spine. And that may, that's just as appropriate as applying an ill-fitting or inappropriate use of a C-collar. So you do see those a little more often. A third of your C-spine injuries die at the scene. Because it may be that they're an upper C-spine and that it happens reasonably quickly, often because of complete dislocation, maybe C1, C2, or lack of, or complete neurological, like transection, cord transection, so there's no breathing. Anything from C3 downwards, you're likely to see some form of neurological deficit with that. Have a look if you've got things like diaphragmatic breathing present, if they can flex their elbows but not extend them, if they've got pain that's above the clavicles but they have no pain below the clavicles, and if you've got signs of like spinal shock, so they're hypotensive, they're bradycardic but they're not hypovolemic, then those are all signs of spinal cord injury. So they may once again direct you to thinking that there's something you're not seeing, but you have to be mindful that we'll treat them as a spinal cord injury and often treat them as a C-spine, because that will then protect the rest of their spine. You tend to maintain them as a log, looking from the neck down, and then that hopefully will give them the best chance of a decent recovery. So just remembering the dermatomes, and I can never remember this, but C4 is clavicles, T4 or titties and nipples is roughly that. T10 is tum-tum or umbilicus, and L3 is your knee level. So just from a rough sort of, trying to remember in the heat of the moment where they are, that could be quite useful. Airway interventions, what you need to do really depends on the skill. Patients don't die from a lack of a plastic tube down their throat. They die from a lack of recognition of an adequate airway or lack of adequate airway management. So think about what you can do. The simple stuff often works really, really well, and anybody can do that. You have to be reasonably skilled to be putting ET tubes in, especially in trauma patients, and it's not something that you should do sort of right off the bat unless you have no choice. Because even the most skilled people make a mess sometimes of ET tubes. So go for your simple stuff like your oropharyngeal airways or Goodell airways, nasopharyngeal airways, so long as it's not sort of significant mid-face trauma. Laryngeal mask airways, most people can put them in. I remember my 2.5-year-old son doing it on a mannequin because he came to a training thing with me one day, and he got it in, and you could ventilate the mannequin, so they're really, really easy. And an ET tube is the gold standard, but it's actually not that easy to get in, and it requires lots of other things with it, lots of drugs and other sort of adjuncts to go with it. So OPAs are easy to use, they're cheap, you size them from the angle of the jaw to the corner of the mouth. Put them in an adult upside down, rotate them once you get them over the back of the tongue, and it holds the tongue forward. In a child, you put them in just straight, okay, not upside down, because they don't have a very hard palate, and so you don't want to stick them in up the top. It does mean the patient has to have a depressed gag reflex, and if you put the wrong one in, it can relate to or can contribute to airway obstruction. It can actually suction down the middle of them and around the outside of them as well. And if you think somebody's having you on, it's a really good way, quick and easy assessment to see whether they are, because you choose something big like a size 4, and if they're having you on, they'll just spit it out and then they'll probably try hitting you. So it's quite useful from an assessment point of that. NPA airways are really, really good as well. You can actually have 1 in or 2 in, depending on what you've got. Gag reflex can be intact with those, and they can have a higher GCS than with an OP airway. And we very commonly use them after extubation of our post-cardiac surgery patients where they snore a wee bit. You'll whip one of these in with a wee bit of lube on the end of it, and they won't even know, and they stop snoring. So, relieve the airway obstruction like from a bit of OSA. And a lot of the partners want to take them home because you've stopped snoring. It's great. But they can't be used in facial trauma. You have to be a little bit careful if you're suspecting base of skull. You can use them, just have to be careful because you don't want them ending up in the middle of the brain. And if you don't put them in properly, they can cause an airway difficulty because you cause a nasal hemorrhage. So you have to make sure they're well lubricated. If you're in a facility that might have, the lignocaine catheter jelly syringes, whack a wee bit of that up the nose and then you put that in, because even if your patient's a little bit awake, a wee bit of lignocaine works a treat, and it means that they're well lubricated to go in. So you hold them, you gently rotate them to get them in, rather than pushing them all the way or coring the nose out by pushing them all the way down. If you rotate them a wee bit like a pencil, then often they'll slip in really, really easily. You may find if you're standing at the head of the patient, one side's a bit bigger than the other, so I'll often go with the one side that's a little bit bigger, or looking at their nasal septum if they're front row forward that's had a couple of bangs, and see which side's the straightest to put it in. LMA is widely available, and certainly from a pre-hospital point of view, even EMTs can tend to put them in, so they're reasonably easy to put in. You don't need to RSI the patient, so you don't need to have drugs available to you for that. It's also part of that failed intubation management drill. And you can use basically a bag valve mask on top of that, and it's often easier than trying to hold a mask on somebody's face. But they don't prevent aspiration. They can be dislodged, or they can actually fail to seat properly depending on how you put them in. And sometimes if you've never seen one before, often it's really common to have them put in upside down. So basically you want the black marking that's on the back of them facing the nose of the patient. So have a wee look if you've never used one before and have a wee go with that. Breathing's really important. People die from a lack of breathing or a lack of adequate breathing and oxygenation and ventilation. And one of the biggest problems is if they don't have adequate ventilation, then you'll end up with significant secondary injuries. So that's where you get your hypoxic, ischemic encephalopathy, and your brain injuries and things like that. Or it may be that you've got something like a strangulation or asphyxiation from a seatbelt. Then the HIE comes secondary to that sort of prolonged asphyxiation. So having really good bag valve valve mask, you know, manual skills is really, really important. Lots of practice, and you can do this without any other adjuncts, but sometimes having OP and NP ways can actually make your life a little bit easier. So really important that you can do that well, you know, be one person with a C grip and doing it on your own, be it a two-person where you've got one person just holding that mask on that face and another person bagging. It depends sometimes on what resources you've got available to you. With bag valve mask, always bring the face up to the mask, not the mask down onto the face. So once you've got the mask on, lift their face up to the mask rather than squashing the mask back down on their face, because what that tends to do is actually push them back down and obstruct your airway and make life a lot harder. Other options you might have available to you might be some sort of CPAP or BiPAP, non-invasive machine, and it might be something flash like a mechanical ventilator like I've got on the screen, the Hamilton T1, which is your red one, or your dear old Dragar Oxylogs, which you might have available to you. Or it might be something simple like a patient's home CPAP that might be available to you, or one of those less invasive kind of machines that you might have in your ED, or even a wall system that your hospital might run as well. So if you're struggling, sometimes putting one of those onto a patient early on, as long as your patient is awake, can also make your airway management a lot easier as well. And that can sort of free up your hands and do all that as well, which is really, really important, because sometimes you need your hands for doing everything else that you've still got left to do. So that's sort of A and B. Circulation, stop the leak. Stick your finger in the hole if that's what it takes. And be a little bit permissive with your blood pressures when you're looking at those kind of things, depending on what kind of injuries you've got. We say that if you've got a TBI and it's just purely an isolated traumatic brain injury, then you'd like your blood pressure to be, systolic blood pressure to be sort of 120 and greater, because that's more likely to give you a decent cerebral perfusion pressure. If you take into effect there might be a bit of swelling already going on the brain, because cerebral perfusion pressure is that mean arterial blood pressure minus your ICP. So, you know, if your blood pressure is sitting a little bit lower and your mean arterial blood pressure is sitting around the 70 and you think, oh, they've had a significant brain injury, and your ICP, normal 0 to 10, anything above sort of 20 you're really worried about, then you're trying to maximise the flow around that injured brain. If you've got uncontrolled hemorrhage, or if you've got penetrating injuries where you can't stick your finger in and grab that aorta or something's flapping around, then systolic blood pressure around 80 is what you're aiming for, because anything further than that, you're actually just going to make them pump out more blood. You're then going to pour in more fluid, which is not sticky and it's not red and it doesn't carry oxygen, so you're going to make life more difficult, especially if it's really cold, because you're going to make the coagulopathy more difficult as well. Warm the fluids if you can, so think about that. Just be careful if you do chuck them in the microwave, give them a good shake afterwards and maybe leave them to sit for a wee bit. And also, this is where you may look at what blood products you've got available to you. So, you know, do you have just standard O-neg red cells? Do you have a wee bit of FFP in your freezers? Maybe a bit of cryo? They're talking about bringing freeze-dried cryo in. They still haven't brought that in yet. It's something they have available in Australia, which is fantastic, because, of course, you just, you know, make it up like any powdered antibiotic. Do you have any platelets available to you? And it may be something simple, you know, platelets, oh yeah, platelet count might be fine in your patient, but they're taking something like aspirin, all those bits and pieces, so they might have good numbers, they're just not going to work. The CRASH trial looked at tranexamic acid. Actually, no, it wasn't CRASH, it was PATCH trial, looked at tranexamic acid administration, and it was trialled pre-hospital, certainly in the North Island, it wasn't in the South Island, and people are very quick these days to reach for a gram of tranexamic acid. It's seen to do more harm than good, so you can sort of almost give it without being too worried about sort of the adverse side effects. It's very rare to get a whole lot of clotting and end up with horrendous clotting problems post that if you've given a gram of TXA. So that tends to be one of the things our haematology colleagues will say reach for first as part of that hemostasis. Normothermia is really important in assisting with hemostasis, so if they're cold, warm them up. Things don't stick really well if you're under 35 degrees, so trying to get them to 35 degrees and above was really good. But also you don't want them maybe at 38, because the hotter you make, the more they vasodilate, so if they are leaking, the more they're likely to leak. Think of putting on tourniquet, and the general rule is if you've got a bandage on and it seems to be controlling the hemorrhage, Don't take it off unless it continues to bleed through lots and you actually have to have a look and see what's going on. Particularly if it's been put in pre-hospital, it may be that somebody's taken a photo on their PRFs that we use on the tablet to show you the wound before they wrapped it up. It might be like that leg that I showed you where actually they did have a bandage on that, but they had the tourniquet on as well, so we actually had to take that down to have a wee look and see what was going on. Certainly the minute I released the tourniquet, you know, is it going to hose everywhere? And I needed to have that wound visible to me to see that. Gunshot stab wounds, we're pretty lucky. Certainly down here in this end of the country, we get really excited if we see a gunshot wound because we don't see them very often, versus somewhere like the US where, you know, 300, 400 people a day get shot and 10 to 30% of those are fatalities. So most of ours tend to be around hunting, you know, duck shooting, and the more whiskey or beer they drink in the mai, the more likely they are to come up with a gunshot. Or they've all done a really good day's hunting and they've jumped on the back of the quad bike and forgotten to unload the one they had in the spout, and they've gone over a bounce and, you know, over a bump somewhere and shot somebody, you know, inadvertently. So for us, I think, you know, we don't have a lot of experience in our gunshot wounds. Probably where I am, you know, a lot of my older cardiothoracic colleagues have done a lot of training in places like Boston and maybe in South Africa, and so they've seen a little bit, whereas the rest of us still get a little bit excited from that point of view. Usually accidental we see, but there are the odd deliberate one, and probably most of the deliberate ones I would see down here are suicide. We don't have a lot of gang issues. We don't have a lot of that. I certainly know up north, you know, looking at Wairoa and places like that, there's been the odd one where there's been a drive-by dump at the front door of the hospital or medical centre, which we're quite lucky we don't see down here. So that may be more, you know, an assault sort of situation rather than what we'd see suicide down this end of the country. Maybe it may have been a child that's found a firearm, although we're quite lucky, you know, from a shotgun point of view, it's very, very unfortunate if a child can shoot themselves. They're more likely maybe pointed at somebody else. A lot of them are hunting accidents, you know, from poorly defined targets. But even minor gunshot wounds may have the lasting consequences, so they do something that need to be taken seriously. Lots of fatal hunting accidents might have been from a headshot, you know, poorly defined targets. They see something movie, they think it was a deer and it's not. It turns out to be a person, maybe like that teacher that was cleaning her teeth at the campsite and not identified as such. Damage is usually catastrophic, often visible, and sometimes the person who's first at the scene can't do anything, and that can be quite distressing and have those ongoing sort of PTSD effects. And so from that point of view, it's not just the person who's shot that is you're dealing with, but you're also dealing with everybody else that's involved as well, which can make your job as health professionals a lot more difficult, because sometimes it's also about separating the parties out, because particularly if it's an assault and there's gang-related stuff, you're dealing with both sides of the, you know, of the war, and you're trying to separate them out when they're having a crack at anybody, including you guys who might be in the middle. So if it's deliberate though, it may be much more targeted. So maybe they've actually shot deliberately at somebody's head, or they've shot at centre mass. So that may, you know, much more likely to be fatal. If it's also deliberate from a suicide point of view, it's much more likely to be fatal because they actually mean what they're doing. They've put the gun under their chin or in the back of their mouth and sort of blown the back of their head off and things like that. So, or it might be something like we've seen in the past where somebody goes a little bit postal and actually chooses to shoot other people. It may be that they've taken out several people at the same time, which then gives you a higher workload. Instead of dealing with one or two, you're then dealing with maybe multiple casualties, a bit like Christchurch had to deal with, where it can, you know, fine in an urban and metropolitan area, but not so easy in a smaller area, you know, places like Wairoa or at presenting at a medical centre, much, much more challenging to you guys as well. And along with that is the threat to your own physical safety. So that's something that can't be ignored. It maybe you've got somebody bleeding on your doorstep and actually it's not safe to open the door. So you still have to think of yourself first. The person's going to bleed regardless of whether you get shot along the way or you get threatened as well. So you still have to think about that as well. They always taught us about thinking about forensic evidence, but realistically that comes last. You know, you think about that, you take it into consideration, but if you have to cut things off, if you have to remove things, then, you know, it may come later. They ask you and it's like, actually, I've got no memory of what they look like. Maybe I've cut this off, I pulled this off, they were wearing this clothes. It may be they say they're wearing something's black, and later on when you find that piece of clothing, it was actually blue. You've got no idea. So don't worry too much about that. It's just something that if you do remove anything and you think there's something suspicious about it, stick it in a bag and don't chuck it out. is probably the best idea, because you may be asked about it in the future. This is a gunshot wound in somebody's head where they've just basically taken off half their head with that. So that's actually a skull that's been opened up, and you can just see it's absolutely cavitation. So basically, as the projectile's gone in, it actually tends to core things out and it spreads. So as it goes in, it gets worse and worse and worse. That's why entry wounds are often small and exit wounds are absolutely horrendous. We don't see a lot, but here's like a CT example of, you can see all the pellets in the side of the face there, along with the actual damage to the, particularly to the zygoma and maxilla there. So you see a wee bit of that. Thoracic and abdominal wounds are a problem because of what they actually hit, but also it's really difficult to get in there and control any hemorrhage versus being able to maybe stick your fingers in a hole or stick your fingers in a brachial artery or even in a femoral artery, because you just can't actually access what you want. You can't see where exactly it's bleeding from. Death isn't always instantaneous either. It may be sort of further down the track from this. It may be certainly, bronchial leaks and esophageal leaks may mean that the patient survives the initial onslaught but dies from sepsis later. Neck wounds can also be a bit of a challenge because you can't always get decent manual compression, and also because if you're squashing on the side of the neck, you may then compromise their airway and even sometimes some cerebral blood flow. Hopefully you haven't got blocked carotids on the side that's not affected, like you'd like to think, and maybe they've still got one side that's working, so if you're completely squashing the carotid on the other side, then they've still got some blood flow to their head. And that can often happen. Those tend to be accidental, some of those neck wounds as well. If you've got somebody who's got unable to talk, hemoptysis, anything like that, any subcut emphysema, any respiratory distress, then often there's a lung or tracheobronchial injury that you're thinking about. And so often the first thing you're going to do is actually stick a tube in and worry about that and then deal with that afterwards. Then you can look at your pneumothorax, your tension pneumo, thinking of your finger thoracostomy, needle thoracostomy, whatever you can get your hands on for a start and going from there. Depends on your skill, depends on what you've got access to. So if you have a quick look on the left of that X-ray, you go, oh yeah, there's a bullet sitting in front of him. It wasn't until they got the CT where you actually look, the bullet's actually sitting in the heart. It's actually in the myocardium. If you look on the right-hand side CT scan, it's sticking into his myocardium. They were actually going to send this guy home, and he did go home, and he presented a couple of days later with a bit of chest pain. And they thought, oh yeah, they did a side, did a lateral view, and it didn't really show up there. It's sitting there, and they thought, oh maybe. And then they took him to CT and go, oh God. So of course then they had to go in through the front of the chest, just with they did a thoracoscopic approach and worked out how they could suck that bullet out and not damage his heart muscle too much. So it's quite funny, looking at things like that. Stab wounds are the other thing that you might see of, particularly from a criminal point of view. Really, really popular over in Britain as a way, and of course they're very targeted. So you will find that they're going to go for groins, for axilla and things like that, or for necks, because they can sort of slash quite easily, and they know that's where the damage is going to be done, and it's quite fatal. But they're also quite easy to get at, so that's what they tend to do. We still don't see a lot of them down here, although having said that, we had a guy not so long ago who got into a bar brawl in Queenstown. In fact, there was a group of them. One of them noticed he was bleeding, went to hospital. The other one got in a taxi, went home, and thought after an hour of not being able to stop this leak in his chest that he better go to the hospital, and he had significant lung injuries, that he was bloody lucky he just didn't die in his hotel room. So not always, A, they're not always common, B, also the person was reasonably intoxicated and not particularly smart, so he actually didn't think about the fact that he just thought he'd been punched and didn't realise it was a puncture wound with a knife. So there we go. Depending on where it is, will dictate what you're dealing with, and also, if you're thinking of it's in a chest, you're thinking automatically of what's underneath that actual hole. Is it a lung? Is it a big vessel? Is it both? Is it the heart? What am I going to be looking at? You might not see anything on the chest. There might be just a tiny wee nick, as the last one that I saw, and then when you actually looked at them, they had a huge hole in their lung, and they'd been stabbed with a piece of glass. The glass had actually broken off, so the shard was still in, but you couldn't feel it, and it wasn't visible until you saw it on X-ray. It's like, okay, we need to suck that out before it ends up sort of putting a hole in anything else. And depending on where it's happened and what it is, as to, you know, like a prison brawl, which they may use sort of like a shank where they can break that off versus a bit of glass or something, versus, you know, a knife that might be used in a street assault, may raise your suspicion of what actually the injury is underlying. So this is a gentleman who rocked up to the ED, I think in Invercargill, and hadn't realised initially that he'd been stabbed because he had a big high collar on. As you can see, there's a few tattoos there indicating it was a bit of a gang brawl. And he managed to miss major arteries and also not lacerate his trachea. God knows how, because when you put your fingers in his neck, they disappeared a fair way in. And I think it's just more than good luck, but than good management on his point. He was really lucky. So you treat them a wee bit like gunshot wounds. Where they are dictates what you're going to do with them, and sort of looking at what else you have to do with them as well. Sucking chest wounds, get out your defib pads, covers them really, really well. Abdominal wounds, if you've got an abdominal laceration, you know, from a stab wound, or quite often not just a stab, but they may pull it up, so you get a bit of an evisceration. Out with the old cling wrap and wrap that round, and certainly pre-hospital, that's what we do. We will glad wrap around their abdomen. You kind of sort of fold in what you can and then just glad wrap the rest, because it basically keeps everything moist. It's not like sticking a towel on where you then have to try and prise the towel off the bowel. You know, you have to wet it first, so it keeps everything quite moist. Limb injuries, quite easy usually with direct pressure. Ones that aren't are if they've actually sort of, you know, punched a window and they've gone through a window up to their armpit and they've lacerated their axillary artery, then often it's your fist in there with a, you know, something on it, hand down on top, and you're sitting or straddling the patient till you get somewhere where you can take your fist out of there. So you do see that occasionally as well. The same with their femorals. It's sometimes like just leaning on them as hard as you can get. Hypovolemic shock, looking at that early recognition of shock. So tachycardia, weak or absent pulses, altered perfusion. So it might be got decent central perfusion, but you've got nothing in the peripheries and you can't find those peripheral pulses. Altered mental state, level of consciousness, bit of agitation. Don't wait for their blood pressure to drop. Looking at you've got compensatory, decompensatory and irreversible shock. So hopefully you've found it when it's in the initial stages and you've been able to sort of deal with it, rather than waiting until it gets to be completely irreversible, that no matter what you do, you're actually not going to get that because all the damage to those secondary tissues has already been done. Stop the blood loss, so that's whatever way you can. Think about your volume replacement, give them some oxygen to be able to get some around to the tissues as well, and only give vasopressors, things like metaraminol or phenylephrine and things like that for their low blood pressure if you've actually restored the volume. If they're still leaking or if they're hypovolemic, no point in giving them a squeeze because it's not going to do any good. The only sort of contraindication to that is if it's a spinal shock thing, so it's neurogenic and you're actually just trying to maintain that sort of, you've got that loss of vasomotor tone, so you're adding into that. Obstructive shock may happen from a tension pneumo, and that may be your stabbings or your chest injuries or something like that. You need to decompress your tension pneumo to stop that shock. Still looking at that second intercostal space, mid-clavicular line if you're going to do a needle. By preference, though, we are teaching that sort of thoracostomy on that fifth intercostal space, mid-axillary line. So making a hole, sticking your finger in and just sort of tearing at the tissues a little bit to get that out there. Sounds horrendous. They might swear at you, but they probably don't notice you're doing that anyway. And from that, you can either go on and insert a proper chest drain later, worrying about, you know, antibiotics and all the rest of it. Don't worry about any local, just make a hole. Cardiac tamponade does occur, primarily sort of from blunt force trauma to the front of the chest, you know, airbags, seatbelt injuries from things like that. And it's where you get a bit of blood in that pericardial space. And so, of course, then the heart can't actually expand to be able to contract and pump the blood out. So it's actually a physical sort of restriction on the outside of the heart. Not a lot you can do about that because that needs somebody with big kahunas and a big needle to go in through the front of the chest and suck that out. So just about recognition of that more than anything else. If they arrest, cardiac arrest and trauma is almost always fatal and unrecoverable. Usually it's because they're hypovolemic and so hypovolemic nothing works anymore, or that you've got significant chest trauma and you've got a decent tamponade, or you've got a decent vessel rupture. You're talking an aortic rupture, big pulmonary vessel rupture or something like that. You may see just PEA. with or without a pulse. You might have a palpable pulse for a start, and you've got what looks like a perfusing rhythm, and then it just disappears. You might have an art line in or something like that. You might have a low output and that just disappears, but you're still getting the waveform on your ECG. Basically, you want to pour in some volume, but preferably blood or something as well as IV fluids. If you don't get them back reasonably quickly, then you're never going to get them back. And that's something that's just completely outside of your control. Reversible causes of traumatic cardiac arrest are things like hypoxia, so give them high flow oxygen, ventilate them, whatever you're going to need for that. Tension pneumothorax, put a hole in their chest, decompress it, stick a needle in for a start, do a thoracostomy, whatever you can within your skill set. Cardiac tamponade, it's all very well for me to say decompress the tamponade because I work in a big hospital and I have, played on sheep and stuck needles in and things like that, but doesn't always work. I've seen 2 thoracotomies, I think, open thoracotomies in my ED in probably the 25 years I've worked in ICU, so it doesn't happen very often. Hypovolaemia is probably the one thing we can treat along with hypoxia a little bit earlier. Blood products and try and control the bleeding really are the things that we can do for that, and a bit of fluid as well. So decent big IV and anticubital. You can put an EJ in the neck if you need to, good 14 gauge or 16 gauge, you can whack in that EJ. And specifically if they've got a bit of a tamponade, of course their neck veins are sticking out quite nicely, so you can actually whack that EJ in without the tourniquet, which works really, really well. So trying to get something in is quite useful. So think about that. If you're really in dire straits and they're starting to arrest, it may be that you're just pouring in litres of just saline or something like that for a start, so you've got something until you can get blood products to you, and then going from there. Some of the helicopters these days do carry it. I know Auckland carries fresh whole blood. I think they've got 4 or 5 units that they carry, along plus or minus some of the other products. So that may be useful from a resuscitation point of view to know that if they're coming to pick you up then, or coming to your place, they may have some of those things with them. You've got your spinal cord injury and your trauma pathways as part of the major trauma network. So have a quick think about where you are. In the North Island, you've got Middlemore, Auckland City, Waikato, Wellington Regional Hospital are all sort of your big major trauma units, and Starship as well. In the South Island, Christchurch and Dunedin are your 2 major trauma units. It may be that you bypass some of the smaller places to get to your major trauma units, for definitive care. It may be that some of your smaller centres are used as staging areas. They may have, some of them, might have a bit of blood product that while you're waiting for the helicopter to come and get your patient, you can put in a few bits and pieces. You can add, you might have access for the pre-hospital staff to be able to access things like tranexamic acid and just some extra skills, but you're not going to delay getting them to that major centre by going backwards or sideways to the smaller areas. You're going to try and get them to definitive help. And that may be putting them in the ambulance and going past some of the smaller hospitals to get to some of the bigger ones as well. Spinal cord injury destinations for New Zealand are Middlemore, Starship and Burwood in the South Island. So they tend to be the ones that you're going to go for, and it may be that they'll overfly, and they do that from us. They'll overfly anywhere in the South Island, lower half of the South Island, if it's an isolated spinal cord injury, and take them straight to Christchurch. So they, we're a major trauma hospital, but we're not a spinal cord specialist, so they'll overfly us. Maybe the same in the North Island, they overfly places like Wellington or overfly Waikato because it's purely a spinal injury, so it needs to go to that specific destination. So that's quite important, and you can find some of those pathways if you jump online and have a wee look at major trauma network or spinal cord injury pathways, and that will show you what's available to you and what your area of destination is specifically for you. If you are packaging a patient for transfer, a couple of big large bore IVs, preferably in each arm, because if you've got them up against the side of a helicopter, you can't get at the left side of their body in my helicopter, so the only side I can access is the right hand side. You can put in an EJ in if you're stuck as well. They can be really useful too, and you're not going to faff around with any other sort of form of vascular central access. Urinary catheter if you can. Nasogastric tube if you can, if you've got your patient intubated. Chest drain if you need to, or just put a hole in it, and we'll deal with that later. Think of, if you can, some antiemetics and definitely some analgesia. Wrap them up as warmly as you can, but you've still got to get access to everything as well. So that's about the kind of the packaging sort of thoughts of things. This is my consultant and I doing a road trip at 3 in the morning, freezing cold. I think the consultant's got a hat on, patient's got a thing around his head. This is when we had no fly Toni weather and the weather was absolutely shocking, so we went by road. So this is kind of what some of our patients might look like. This is an intensive care patient, fully ventilated, fully monitored, art line the whole lot in, and he'd forgotten to blow on his pie, and as he'd forgotten to blow on his pie, he walked out in front of a Mack truck and was hit and went flying. The only thing he lost was 2 of his jandals, 1 of his teeth, and he did break his ankle and nothing else apart from a bit of skin off. So how on earth he managed that, I've got no idea. And I think that's about me.
Wow. Totally amazing, Toni. Thank you so much. I had to laugh, you know, you covered so much that within half an hour there's people going on about how they totally enjoyed your webinar and it was the best they'd seen yet. And I'm thinking, geez, you've not even got halfway through yet. These must be your friends, Toni.
It must be. I tell you what, I think I'm really, really lucky. I've been a St John volunteer since I was 16. I was brought up in a small rural place and then came to Dunedin to go to uni or go to tech and learn how to be a nurse. And I've stayed doing that. So I've just finished 2 nights working on the road on my days off from my day job. And so I've done that along with ICU. So I get to see the best of both worlds. I get to see a wee bit of, and remember what it's like to be in that situation if you're the first person. And I still don't forget, you know, so I don't forget that when I get to go flying and think, you know, when you walk into a small place and you might go, oh my God, you know, why haven't they done this and this? It's like sometimes actually they don't have this and this to be able to do it. So I think for me that keeps me really, really grounded. And I think it's really quite useful because I get to bring you some gory photos and bits and pieces. And I think sometimes maybe, you know, be able to give you that wee bit of credibility that goes with it.
Yeah, give us all nightmares. Thank you.
Oh, yeah.
So we've got a few questions here. So have you got, is it all right, we just run through a few of these?
Yeah,
some of them are just comments and some are questions. So
yeah.
we've got, why are we not seeing SAM pelvic binders in the rural sector with Primer St John's? This is evidence-based practice with known improvement in patient outcome.
A lot of it comes down purely to economics, and as you're very well aware at the moment, there's a lot of press on St John. St John is not fully funded by the government, so it's not like the fire service or the police. And a lot of our equipment comes down to your local area committee fundraising for some of the stuff that you have. That's why I've got access to things like IO drills and things like that. And your small areas may not, because that's $500 or $600 that don't exist. Same with the pelvic splints. They're fabulous, but actually at the cost of $200 or $300, when they don't always get them back, you know, that's something that's seen as kind of non-consumable. So that's why they're not always available. A lot of that kind of stuff is getting better at being funded, but sometimes you still have to go back to the old tried and true of using things like your, you know, sheets and things like that we've done in the past, and tying knots and things and doing your best. So that's often what drives it, is pure economics.
Thank you. And then this one's more just a comment. So with agitated TBI, sedation and oxygenation are important components of patient management. In the context of the rural setting, this can be problematic while managing O2 resources, pharmacology stores, etc. So that's just a comment. And then someone saying about how it's the most intelligent webinar they've seen so far. That's pretty cool, eh?
Thank
and
you.
Then, and then we've got someone asking about, will Prime ever supply bougie as a rescue device? I thought, because we carry bougies in our kits up here.
Yeah, and I think it's really interesting because one of the biggest problems that used to be with bougies, of course, that, you know, they wouldn't fit into anything. And the minute you bent them, they were no use for anything else. And it's something I think that's reasonably common these days. If I look at intubation, when I first started in ICU, you know, bougies were only ever used if you were crap at your job and you needed a bit of help, or if it was grade 3 or grade 4 airway, whereas now it's commonplace, and that's inside a hospital. I think we're certainly pre-hospital trying to encourage that from a St John point of view. They do have them. Sometimes you'll find them tucked under the stretcher and that to keep them out straight and keep them used. And the one thing that we've actually introduced in our area from our flight services, you can get foldable bougies that look like foldable tent poles, and they're worth about $20. And you clip them together like a tent pole and they actually make a bougie. And you're quite right, you know, it's about, I think, trying to bring things like that on board that we know, a bit like the SAM splint, that there's really good evidence for things like that. And I think sometimes because Prime and your Prime kits are funded partially by St John, but usually by your practice that you're working out of. Sometimes it's, once again, convincing the practice that it's actually worth having that piece of equipment. They're not as expensive as they once were. Of course, once upon a time, we used to have the gum elastic bougies that used to reuse, a bit like the reusable LMAs, whereas now everything is much cheaper and it's all disposable. So sometimes it's about, if you don't have access to them, it's about going back to your practice and saying, hey guys, we need to use these. Maybe you can come up with a purchasing agreement with your local hospital. We're a bit like drugs sometimes. You know, we're very well known down here for, if we turn up to some of the smaller places that don't have a really good drug supply, we'll bring extra with us. And if you've used, you know, we've got lovely friends in Wanaka, and Jonathan Wills is one of the doctors there, and he'll go through his rocuronium, and it's like, well, you can have mine, because you've already rocked the patient, life's good, and we'll just swap things out. And we often exchange things like that, or we might take a wee bit extra knowing that they've used their supply, and we'll just give them what we've got, particularly in the weekends where they have no access to being able to, you know, to order more from pharmacies. So sometimes it's about who comes to help you, and maybe having that relationship with your local people, where we'll often take half a pharmacy and just leave it behind with us.
Very good. You keep up that good work, Toni. Now, what we've got here is we've got someone who's here saying, in a motorbike accident, would you remove the helmet? Would you remove the helmet when throwing, trying to see their airway?
Routinely, yes, I do, but that's going to be at least a two-person job. One person who comes from the front and is holding the neck from the front, while the other person is removing the helmet. So the person behind the patient is the person removing the helmet. And what you do is you pull the straps apart at the front, you know, down where because usually these days they're full face. So you grab the two straps, you pull them apart, and then you're going to just gently rock the helmet forward and backward. You just have to be aware that the person holding the neck and the head, when you're just about ready to take the whole helmet off, just make sure they're aware, because all of a sudden the weight of that head's going to come onto their hands, and it's automatic for the head to go backwards a wee bit, because of course your head's quite heavy. And if you stand up against a wall, there is a gap between the back of your head and your wall, unless you're pushing your head back. So once that's off, you have to be careful that you've got something to put underneath that head, you know, folded towel or a jersey or something like that. So yes, I would routinely remove the helmet. If they've got a full face on, you can whip the visor up and have a quick look. Then you can do that until you've got two pairs of hands to be able to take that helmet off. Yeah, once again, you're going to take it off. You're going to bring their neck back into neutral alignment if they're rotated slightly, but you have to take it off to be able to have a good look at their airway. Yep.
Cute. And then we've got someone just commenting about, like what you said, about some of the rural places funding their own, so like the IO access, about the need to do that. Now that comes from Cheryl, and she's hoping she can, Cheryl Eden, and she hopes she can catch up with you sometime.
Hi, Cheryl.
Kindest regards.
Yeah. Things like the easy IO drills are much cheaper than they used to be when we first bought ours, and we've actually had the training drill with our service for 20 years. It's only just finished. It's just run out of battery now. They used to be something about $2,500, and I know now they're about $400 or $500. So sometimes it might be one of those, you know, Lions Club want to buy you something like they used to buy defibs. Nowadays they're looking at things like that. Local service clubs, Lions, Rotaries and things like that, you could approach those kind of charity support for things like an IO. You can still get the old IO needles, and the Cook's needles are a lot easier than they used to be, because they're actually a little bit, they're more like, I guess like a corkscrew. So they're not round like a button, they're more like a corkscrew. So they are easier to use. But yeah, if you can approach maybe one of your local service clubs, they may fund you a drill. And once you've got one, I know the consumables are pretty pricey, but sometimes if you're a bit like us, you might be able to get us to leave a couple behind at a scene, or the helicopter might do that as the helicopter takes off as well. So that's something to think about, just from, looking at your practice, or, when you're looking at putting funding applications in, it's something you can specifically ask for that can be tagged, this family donated our drill or something like that. So it's something that may be a different avenue of doing it.
Lovely. And there's someone else saying you're an inspiration now as well, Toni. You should ask, I should write all these down for you, all these words.
No, because it really will make me embarrassed.
And then just around the tranexamic acid, I was just saying about when would that be widely available to rural practitioners as prime responders. But then someone called Nikki said that it is now available to prime, but it's only rolled out in the last couple of weeks, so to get in touch with a coordinator.
Yeah, it's just something that I think they were still continuing with the patch trial, and then they've actually abandoned the trial in favour of saying actually there's nothing really that's detrimental about it. So I think everybody's basically, as Nikki says, tick the box and it's starting to come out. And because you're seeing it a wee bit more, you know, for things like even menorrhagia and things, the oral forms of it, it's something that's sort of a bit more widely accepted all round. And certainly you wouldn't be faulted for banging, you know, a gram of that in. So 2 amps, reasonably quick push, IV push, you can get hold of that, and it's sort of it should be rolled out sort of reasonably widely, reasonably quickly.
All right, well, thank you, Toni. You've got through everyone's questions, like just as well as you got through the whole presentation. And it's been fantastic to have you. And I think everyone has taken away new information, refreshed information. You've had radiographers, prime responders, rural nurses, St. John volunteers, medical, aged care, all online this evening with you. So you've reached out to lots of people across New Zealand. Thank you.